Today on Nerd and Normal, personal technology and how doctors can help you stay healthy.
Welcome to Nerd and Normal with Matthew and Gareth, opening your mind to the world of technology. So let's get started.
Matthew, how are you today, my friend?
Not too bad, Gareth. Bit enjoying a bit of calmer weather right now. There's no bushfires, there's no madness. It's not too bad right now, so let's enjoy what we can.
Yeah, you're in one part of Australia where that may be applying, but in this part of Australia, they're not necessarily the same situation. However, we are going to talk about NAPLAN and its failure a little bit later on in our program. But as you said in the intro, it's a very important topic: medicine, health, and the use of technology. What's involved? What are the difficulties, etc.? Well, we're privileged. Let me just introduce our next guest, and she's a really qualified person. It's Dr. Caroline Murtagh. Now, she's an Australian-based medical professional who is also trained as a palliative medical specialist and practices in the area of Lara in Victoria. Caroline graduated from the University of College in Ireland, and she completed a number of postgraduate diplomas in palliative care, child health, and also dermatology. In 2017, Caroline co-founded a palliative care service in the Geelong area, the Palliative Care Group. Now, with the aim of looking after patients with a limited life expectancy and family support, Caroline has a special interest in addiction medicine, working closely with Geelong's drug and alcohol services. After that long introduction, Caroline, welcome to you.
Thank you.
I got a silly question to start with. A GP. Some people say a GP, you go when you're sick and you get a tablet and you get better. Would I be right in assuming that the real philosophy behind general practice is preventative consultation? Is that a fair assessment?
Yeah, so actually only in the last 6 to 12 months, they've now introduced preventive medicine as a specialty, and or they've renamed it. So we call it general practice in Australia. In the US, they call it family medicine. And but I mean, essentially, that's what general practice should be. It's preventive medicine. So you see people who are largely well, but unfortunately, none of us stay young or well forever. And what runs in families, you can't help your genes. So what run in families tends to continue generationally. So originally, general practice was set up at looking after whole families. And what happens to grandmother or the mother, you can prevent it happening in the younger generations.
Okay.
Yeah.
Well, I've got a specific technological question to start with, and I'll hand over to Matthew. In your practice in Lara, in your general practice in Lara, how has electronic medical records changed, if at all, the way you consult with patients?
I don't know that it hasn't really changed it that much. It hasn't. I guess it's patients are becoming more mobile. So I guess the ability for using my health record, the ability if they choose to opt into my health record, the ability for their full medical history to follow them around Australia, wherever they're traveling, would be beneficial for everyone, the patient in whatever hospital they wind up in or doctor they see. Not everyone opts in for that, but we do offer it to everyone. So I suppose that does make good medical sense for the patients. Yeah.
Okay. One thing I've noticed with that My Health record, though, is doctors sometimes don't want their patients in there. Have you found that with other doctors you've dealt with in the past as well?
Oh, no, I think it's mainly patient driven. I've in a number of cases I have at the moment, the elderly parents are living, semi-rurally in Lara, and the children are overseas. So they find it good because they can access each consultation that I have and see what's actually going on. Patient, as they should be, patients patients, everybody likes their confidentiality, and and who's reading it and where can it go and how can it be hacked. So that is a concern for people. So there's not a small amount of patients that have opted out. Yeah.
So on that very note, are there any privacy or security concerns with general doctors when you are looking at a digital set of patients' records? Is that a worry?
No, I mean, not so much. With my health record, by the way, what had to happen was that everybody automatically was opted in unless the person actually manually opted out.
Right.
So a lot of people, most people have opted in and are linked, even though some of them didn't realize they had to opt out by a certain amount of time and stuff like that. And then we have had patients who want certain things removed from their active medical file, which I'm not able to do because it's still current. That that's been an issue, but mainly it does work well. It's just for people that are like I said, they're being seen by a doctor that does not know them. They're not in their local place, and it allows their history to follow with them. Before that, it was just a piece of paper, a health summary.
Yeah, I know that your practice is incredibly busy, and you as the doctor have a choice of either seeing a person face to face in the surgery or doing it via telehealth. How do you compare those two? Does one have a greater advantage over the other, or are they both equal?
No, I think like, where are you based, Matthew? What state you're in?
New South Wales.
Yeah. I mean, no, like I don't, telehealth was introduced during COVID. I understand completely then when we're in lockdown why Medicare and the government decided to bring it in. I'm not quite sure why they've decided to continue on with it. I mean, telehealth is not medicine. You've got a patient at the end of the phone. Most of the time you can't see them. You can't examine them. You're relying on whatever they tell you. It will never, it's significantly inferior to a face-to-face consultation. I avoid it like the plague. I mean, if it's a medical certificate or a carer's certificate or a prescription that I've given to you 1,000,000 times before, the dose hasn't changed, then that's fine. I think that in some scenarios, telehealth would always be a good idea. Like if you're on a 100,000 acre cattle ranch in the middle of nowhere and that's your only access to medical care. But I think like in the cities, telehealth is overused when a face-to-face consultation would be better for the patient and the doctor. By the way Medicare have set it up, it's not ideal in that. So, the doctor is remunerated the exact same amount of money for a face-to-face consultation and a telehealth conversation.
Could that
you
be
can't
the
take
reason
your blood.
why?
Sorry.
That's the reason why a lot of doctors are now moving towards telehealth, because they can try and push through more people on a conveyor belt.
It's easier to talk to a person on the phone than it is to, have easier. It's more time efficient to talk to them on the phone than have them in your office. And I mean, you could run a successful telehealth business from your home office with no overheads. But the quality of care that the patient gets is not the same. Like, you can't examine them. You can't, especially mental health. It's very hard to gauge someone's mental health. Most of them are not video calls. Most of them are just phone calls. So you've no ability to gauge their mental health, how they're going. Are they dressed? Are they showered? Is their house dirty? Do they look okay? just the basic. Does this person look sick or well? You can't do that via telehealth.
Even a video call, though, if I walk into your surgery or any GP surgery, one of the first things they do is take one's blood pressure. Well, at the moment, with even excluding the possibility of AI, you can't do that with a video call or with a telephone call.
No, you can't. And so, I think that telehealth is good, but it's overused now. You and I have had this conversation before, and you can't fight human nature. It's easier to do a telehealth than a face-to-face, and easier for the patient, easier for the doctor, but it's not necessarily good for either. I think we've talked about this structure of billings before, because I largely run a bulk billing practice, Matthew. Which is something that I choose. And the way Medicare structure the remuneration for consultations that you do, basically, it should be structured that for a standard consultation, that the top of it should be house call, where you're going to someone's home who cannot leave their home. And you're visiting one individual at a time, then that should be tiered, that nursing aged care facilities are below that, and then appointments in the rooms are below that, and then telehealth is below that. But during COVID, that's not what the Medicare did. You get the same amount for essentially you get the exact same amount for a face-to-face consult and a telehealth consult, and you almost virtually get the same amount for a house call or a nursing home visit. And then that disincentivizes doctors from visiting people at home and in aged care facilities, and then that's where the crisis comes from.
Do the wearables like the watches people wear these days, or even the things you buy at pharmacies to check your blood pressure and have that linked to your phone, does that help you at all with those telehealth or even in-room consultations?
I guess, yeah. I mean, a little. We've always had in medicine white coat hypertension. So in Ireland, the doctors still wear white coats. They don't do in Australia. But there is that idea of when I go to see the doctor, my blood pressure goes up. But when and that's a consistent thing, it won't fall. It will always read high in the doctor's room. We call it white coat hypertension. But then when patients are at home, their blood pressure is normal. So if you've got a good patient who's got some kind of medical insight or awareness, and they've got a good blood pressure machine, and and they're able to use it, then yeah, it is valuable that if they tell you, this is not the reading I get at home. At home, I'm 120 on 70. In your office, I'm 160 on 90. But this is not where I am at home. So I believe the patient in that scenario, and I'll adjust their medication according to that.
Caroline, I'm probably guilty of this, just as many other Australians. Google, part of technology, the computer. If I get something and I wonder what that is, and I go into Google.
It's cancer. It's always cancer.
Yeah, it's always cancer. I go onto Google and I give the symptoms, and it gives me an answer. How much against that kind of diagnosis would you be?
I'm 100%. I'm 100% against it. I mean, the whole idea of general practice and preventive medicine. So if you go back to that concept, it would be, if it's true preventive medicine, they've changed it. It seems almost natural to say preventative, but that's not the word. They've said preventive. And the whole idea of preventive medicine would be that you are coming to the doctor for a consultation when you are feeling well and have no symptoms. That's the whole point, because the idea of symptoms they are symptoms of a condition that you have, and you probably had for a while. And now when you're reporting symptoms, that can be a sign that, you've gone from stage 1 to 2 or 3 cancer. So, it's a bit like I say to I think the frequency, what I say is the frequency that patients need to visit their GP should be based, obviously, outside of their medical complexity. It should be based on like their age. So if you are in your 20s or even 30s, you know, you should go to the doctor, a GP once a year. And then in your 40s and 50s, twice a year. And then in your 60s, 3 times a year. In your 70s or 80s, 4 times a year. In your 90s, if you're 90 and home alone, I see you every month. If you're 100 and home alone, I see you every month. Because it's not a question of if something goes wrong, it's a question of when it goes wrong. Yeah. And so, yeah.
And so I better make an appointment tomorrow.
Well, you know, the 40s and 50s tend to be the most resistive. So I just say to them, you know, you service your car twice a year. So you should service yourself twice a year. If you wait to bring your car to the mechanic when there's a rattle under the bonnet and there's smoke coming out, it's going to be a bigger problem and it's going to cost you more money, you know. So, and similarly, I only had this conversation with someone yesterday, but you know, doctors really can be very obstinate, cranky, disgruntled people. And the thing is that, you know, the 20-year-olds, the 30-year-olds, well, the 20-year-olds and the 30-year-olds, they still need to come because 1 in 6 of them has an STD that they're passing along. Okay. So you need to go for that reason. And then the other thing that we have, because it's a very working class population, Matt, where we are, and the thing is that, you know, dealing with TAC and work cover is very, very difficult. So you can be completely well, have absolutely no medical problems. If you don't have a relationship with a GP and then are involved in a motor vehicle accident or a genuine work cover injury, essentially nobody will take you on as a new patient who's going on to those things, because there are hardest patients, because it's doctors dealing with lawyers. TAC work cover, they don't pay. They want endless letters. Yeah. And I mean, I'm so busy. I have a policy at the clinic. If the patient is completely not known to me, I've never met them before, and they've been involved in they're only coming to me because they've been involved in a car accident or work cover. I mean, they can go on a waiting list, but they go to the bottom of the waiting list. Yeah. And so, you know, you always need to be on some doctor's books for that reason.
Okay. Caroline, in my job in the media, like Matthew, AI is always a threat to replace me. A musician is always worried about, is AI going to replace them? A person who writes commercials for television, will AI replace them? As a doctor, as a specialist in your area, does the existence of AI cause you any worry, any angst, or it's just, it's never going to replace me?
I hope it never replaces me. You know, look, I'm probably the wrong person to talk about this. I don't know a huge amount about it. The whole idea of it scares me, really. You know, there's a lot of studies going on about AI. I read something recent, a study out recently, and it said that, which was through, you know, LinkedIn. It was in a renowned journal, but they said that in patients with, in emergency situations, in patients of high acuity with symptoms, AI was 50% inaccurate in telling them that this was an emergency and they needed to go to hospital. 50%.
Yeah.
There is a study out recently in the New England Journal of Medicine, which said that AI's diagnostic accuracy could be as high as 85%. And then then worryingly, the next sentence was, that was more reliable than most physicians, you know?
Yeah. Okay.
But no, I don't. I don't think that it's a step forward. I think it's a step backward. That, I mean, the idea for me that a patient would even, like, if you like, especially that AI emergency situation. So if you had central crushing chest pain radiating down your arm and you couldn't breathe, even the idea that a patient would turn on their phone or computer and that they would even think of using AI to Google their symptoms and try and get a diagnosis before ringing 000. You just need to ring 000.
Yeah.
So, you know, you see a lot of patients. I don't mind patients, you know, especially patients that have good medical awareness. I don't mind them saying, look, this is what I'm feeling, and I've done some research myself, and I'm thinking it might be X, Y, or Z. There's a lot of areas that and that is more important in areas that are almost less medically acute. Like, you know, in Australia, you guys call it emergency department. In most of the rest of the world, it's called accident and emergency. So, you know, in the case of something that's not an accident or emergency, where it's a chronic, you know, probably benign condition, the patient wants to do a little bit of research themselves, I think it's okay. And they bring that information to you. But the idea that someone would be using it to self-diagnose and then avoid going to the doctor, or, you know, and this is why I mainly bulk bill my patients, Matthew, they're doing that because they don't have the money to go and see the doctor. You know.
Well, that certainly makes me feel good about the problems of AI and radio. Look, I think it's beholding on me, Matthew, as Gareth, as the normal in this conversation. It's important that I actually admit my connection. On radio, I would have to do it. Dr. Caroline is, in fact, my GP, and in the 966 years of my life, that's why I've got to see her every day, I've never come across a GP who's in her diagnostic skills is so turned on. And that leads to the question, Caroline, because the mountain of technology grows higher than Mount Everest every single day, what do you as a GP have to do to stay on top, not only of the technology, but the ways you have of diagnosing or giving a prognosis for someone?
Well, you know, I'm doing it now, showing my age, 21 years. And there's not, that's the thing, going back to telehealth versus face-to-face. Like, you know, it's very, very rare at the end of a long working day that I haven't learned something that I didn't know, whether it's from, you know, a colleague that you're referring to, that you ring to discuss the patient with, from the patient themselves, from the nurse, you know what I mean? You know, from something that you read, you know what I mean? And that is the thing. So even with telehealth, I think that being at work, being in the office, seeing patients, examining patients, touching patients, you learn something every day. Every day you're learning. But yeah, I mean, we've compulsory CPD, and which was a triennium with the College of General Practice. And
what is a CBD? Sorry.
CPD is continuing professional development.
Okay, right.
And you have to show that you keep up with that. It's 100 points or 100 things that you act on. And you must meet all of them once a year. And within the RACGP, which is the General Practice College.
Yep.
And then I do double that again with the Royal College of physicians.
Look, there are many, many things I'm sure Matthew and I can continue to ask of you. And I know you've said you've already been working all today, so you're obviously very tired and may even have more patients to see. But Matthew, unless you have another question.
One more quick question, actually. Doctors are notorious for bad handwriting. So how has prescriptions, now they're electronic, has that actually made your patients have an easier way of life because there's no more guessing from the pharmacies?
Well, doctors, no, doctors haven't. We've always been using computers in the office for since I came to Australia 17 years ago. So in the office, the scripts are generated via the computer, but the difference is we would print them out and hand them to the patient. Okay, so they were legible. They are legible. So the only time I do handwritten scripts are when I am literally in someone's house and don't have a computer in front of me. But normally, yeah, doctors writing, no, it has not become more legible. But normally doctors can read other doctors' writing and pharmacists can read other pharmacists' writing. But that's the thing, Matthew, with electronic scripts. I can write a script for 200 endone and send it to patient X's phone. They can forward that script as a text message to another person, and that is filled in the pharmacy.
Okay, I look, being the older of us.
That is worrying.
Yeah. It is worrying. And being the oldest of these three people on your screen right now, I can honestly say when I was a teenager, I could never read the GP's handwriting, ever.
No.
But things have improved.
Things have improved. Things have improved. But so no, all scripts are printed now except at home. And so that electronic scripts does work well. But I think during COVID it was needed, but I'm not sure. I think that ideally it would be capped down a little bit more on, there's no criteria. There's no set criteria for these are the things that you are allowed book a telehealth appointment for. So, like for example, you'd imagine if it's for mental ill health reasons, you'd imagine it's best to go and see the doctor. But no, that doesn't happen. So, scripts that you've had before, medical certs, carer cert, I think it's wonderful. But outside of that, no, I don't put any value in it.
Okay. Dr. Caroline Murtagh from Lara in Victoria, and my doctor, thank you very much for your time. It's been most edifying. And Matthew, I think perhaps we better talk next week about NAPLAN rather than today, because no doubt someone's going to want to go now and ring up their doctor to make an appointment tomorrow to see their GP. Remember the ages that Caroline said when you have many times you've got to see the doctor? And could I say, if you do not have a GP in your litany of people you see, find one. Make an appointment. Become a regular patient with your GP wherever you live in Australia. Caroline, have a lovely day and thank you for your time.
Thank you.
Thanks for joining us, Caroline.
Thank you. And just you will never tell your GP anything that they have not heard before, seen before, treated before, cured before, done themselves before. You'll never tell us anything that will shock us.
Thanks for joining us.
It's been great, mate, Caroline. Next time we have a medical problem, we can come to you.
Good. Good night. Thank you.
Take care. Well, there we go, Matthew. NAPLAN next week, yes?
Yes, NAPLAN next week.